Log on, tune in, find out. Another good idea from Cambridge.
All right, so there's the title of my talk. It's sort of a amalgamation of what I've been doing the last couple of years in relationship to looking at two agents at the same time, and specifically in the phase 1 setting of dose finding. So this is a teaching with a stick. We'll have to try this at Michigan. This is pretty cool. All right. So the outline of my presentation is pretty standard here. Some of this I'm going to fly through. If we're learning from prior information, I have about 2 times as many slides as I need. Introduction to a basic phase 1 design for one agent. 3 things here, designs for looking at 2 agents simultaneously, and then some thoughts if we get that far. All right, so for a single agent, really there are 2 options here, and we spent a lot of time today talking about Bayesian approaches to phase 1 trials, and I'm in a world where I'm beating people's heads trying to get them to use a Bayesian design. It's not the standard, at least where I am at.
Use a stick.
Yes, I need a stick. So there's the algorithmic approach, right? A plus B toward 3 plus 3, bias coin design, and others. You give a dose to a bunch of people, you see what happens, and based upon them, you decide what to do next. Should you stay at the same dose, go to a higher dose or a lower dose if you allow that. A lot of the talk is about adaptive designs. The CRM, if you're familiar with phase 1 designs, is sort of the beginning of all of this. And as I said, the many, many variants on the CRM and other designs. And the 2 things in violet are sort of what we focus on in adaptive designs that are different from an algorithmic design. And the first is to pick some sort of model. And I'm going to be fairly simple here.
Sorry, my time is
No problem, Kyle. That relates, yes. The stick is becoming more and more crucial here, isn't it? So we've got to adopt some model that says how the probability of DLT is going to relate to what dose I give to a person. But then a lot of it is the same. You give that dose to one person or a bunch of people. You see who gets DLTs. You use that information to estimate the parameters in your model. And then you use that information to decide what to do next. And you do that in relationship usually to a specific targeted DLT rate. These algorithmic designs, certainly there are papers out there saying for a specific algorithmic design there is a targeted rate somewhere in that design, but nobody knows what it is. And unfortunately, everyone uses the 3 plus 3 without realizing what that targeted rate is. And it actually isn't 33%.
But it is adaptive, right?
It is adaptive, right? It uses information, yeah. Yep, yeah. But maybe not the best adaptive approach.
It's myopic.
It's very myopic, right? It's the current 3 people. All right, so now we're going to talk about trying to go to 2 agents. And again, if you look in the literature, at least in oncology, I find is unfortunately what people will do is take the 2 agents and say, well, I can only run a 1 agent design that I know of, so I'm going to fix doses of 1 agent, right, and study doses of the other agent. And with no rationale, right, of which one you fixed and why you fixed it at that dose and so forth. Which is unfortunate, again, because there are lots of designs. I'm not the first person to have looked at this. There's people in the room here who have published designs to look at 2 agents. Some issues that, is that we run these sorts of studies. Others will run these studies. I have not actually run one yet. Figuring out appropriate escalation and de-escalation in the context of 2 agents. So the first question is can I increase the dose of both agents simultaneously? Is that too risky, or would a clinician allow me to take both agents and increase them both at the same time? Should we increase the dose of one agent and decrease the dose of the other? Does that really make sense clinically? And what Jack referred to earlier as the ethics of the patient versus the trial, I came up with the terms local parity and global parity, and it becomes more difficult in the setting here. Local parity, I say, is the patient comes into my trial and I want to make sure I give them the best thing for them. Global parity says, have I explored and learned enough in this trial so that when I leave this study, I go away with the answer I think is best for everybody else. And I think it's something I didn't think about in phase 1 trials with 1 agent when I first started working in this area. And it becomes a little more difficult here with 2 agents. So I just put this slide up here not to be inclusive, of course. If you want to go all the way back to 1967, certainly Plackett and Hewlett weren't looking at phase 1 trials, but they certainly were looking at modeling how two drugs or two agents how you could model that on some binary outcome. And we move along here, names of people in this room, so forth, that have done this, and there certainly are more papers. We move down here, I'm already missing a bunch of people, but I'm in the room, so I get to cite my papers here. So I've got a couple there, but there are certainly more out there. I don't claim to be coming up with the best or right idea here. Basic notation here, we've got two agents. I'll have little m doses, of course, that are ordered from lowest to highest of one agent, and little n doses of a second agent, ordered from B1 through Bn. And I'll use JK in parentheses to denote the combination of the doses of each of the agents. And then I've got some probability PJK that says what's the probability of a DLT for someone who gets that combination. And again, if you do enough phase 1 trial, I'm designing these AJs and BKs. These are not actual clinical doses in many settings. They're numbers that we come up with that make our model tractable and work well, with well defined very vaguely. Right, so that's the basic notation across all the designs. Now the algorithmic approach here, just to make everyone cringe. So in the Journal of Clinical Oncology, it's probably been 2 years now, there was an editorial by an oncologist who said, these multi-drug studies need to be improved upon, and of course his suggestion was, well, don't use a 3+3, use a 3+3+3. Right? So I said, well, let's try that out. Let's just see how bad it is, right? That's really where I was coming from, because I've always been taught that these algorithmic designs are not worth much. So the A plus B plus C, so again, A plus B, A, B, and C capital are the number of folks that would be in a cohort. So you're going to assign capital A patients to some combination, and you'll see how many of those folks get a DLT, little NA. And then you'll compare that little NA to some thresholds to decide whether or not to escalate, stay at that dose with more folks, or move down. And I probably should show the picture first. So if there are too many DLTs at that combination, then you sort of step back and you start two separate trials, de-escalating the dose of one of the agents and then possibly escalating the dose of the other agent. And this is much easier to show in a picture than in words here. But again, if you have a certain number of DLTs and you want to stay at that dose, then you just repeat yourself with a new group of capital B patients, which could be different from capital A. You do the same thing again. And again, if you see between your two thresholds a certain number of DLTs, you might stay at that dose and assign capital C patients and look some more at that dose, that combination, and see what happens. And at that point, either you're going to escalate or you're going to stop with that capital C.
Drug interaction included?
Is there any drug interaction?
Drug interaction.
Other than giving the combination and seeing what happens? There's no model here, right? So I just give that combination, and if there's interaction, we'll see it later in a different combination, but I don't model it.
So what's the objective?
To find the combination that, there you go, there's no...
But there's more than one combination that does...
There will be two combinations you will see in the end, usually. There will be two combinations. The question is what do I say about those combinations? They have a DLT rate of... Right, there's no target here. I just move through. And I think I'll hopefully get to that point at the end of my paper here. So again, one of the issues that I again glossed over here is, suppose you don't see much dose-limiting toxicity, the rate in a cohort of folks. Well, what do you do? Because I wrote up here, you could assign a new group of patients to increasing one of the doses, increasing the other dose of the other agent, and keeping the other one fixed, or increasing both simultaneously. And quite honestly, most clinicians will cringe when I say I'm going to escalate both of them. Right? They want to stay here at least for a little bit, or stay here for a little bit and see what happens before. And I call that slow escalation, when you escalate one of the agents, and I call this fast escalation. And I did some work with Peter Thal in a sort of different setting as well, and others have seen this in their work, that you really don't increase the risk of DLT, and you actually hurt yourself. So a schematic of slow escalation, again, would say I would start here, and if that combination looks safe, I would assign cohorts in both of these directions simultaneously and run both of those. And then assuming that both of those turned out to be okay, then I would go here and enroll one cohort. And likewise, if that turned out safe, I'd again go in both directions, so twice as many subjects, and then I'd eventually get here. Whereas fast escalation is going to start there, but it's going to say immediately, if this combination looks safe, let's just go here right away. And if it's unsafe, we'll move back later. But for the sake of getting up as fast as I can, if the right answer is up here, it's going to take a long time via slow escalation to get up there. Whereas fast escalation, we're talking 1, 2, 3 cohorts, and we're there, assuming everything is safe. Right? And again, in simulations, we found that using this attempt, using fast escalation, really doesn't increase the observed DLT rate in most settings. And in fact, gets you to the right answer more often when the right answer lies up here somewhere.
How did they de-escalate? How did they de-escalate?
I'll get to that in a second. Yep. So this is just an example of escalation. But here's a hypothetical trial. Let's say we've got 4 drugs of both of the agents, or four doses of 2 different agents, and we'll start down here. So using fast escalation here, for example, if this combination, this is the problem with the stick though, it needs to be retractable, huh? Let's say the combination 1-1 was safe, we escalated right away to 2-2, yet we're safe. We got to 3-3 and red indicates too much toxicity. So we want to move back. So what we do is do 2 separate trials. We de-escalate the dose of this agent in one group, and we de-escalate the dose of this agent for the other group. And if those turn out to be safe, then we can move up this way, and we can move over this way. Right. And if we then did that, and in fact now these 2 combinations turned out to be unsafe, then the trial is essentially over. There's nowhere to go. And these 2 prior combinations would be my answers as the maximum tolerated combinations. So again, to get to that question here, there are 2 answers from this trial here. Which isn't a bad thing, I don't think, right? I don't think we necessarily need to have one answer to move forward with.
I guess my question was more
Oh.
of the off diagonals.
Yeah?
Because you noticed if you go to the second diagonal,
Whoops.
just this part.
Yep. Right here?
And before, go back.
Go back. Back.
If
Right.
you hit 2-2, yes.
If I hit 2-2, okay.
Right. So regardless of the fast or slow, there is no mechanism to allow you to explore 1 and 3 and 3 and 1.
There is not. To de-escalate one and escalate the other.
Right. And the assumption is unknown. You don't know which one.
Correct.
Yeah.
Right. So in this design, there was no possibility of that sort of attempt. Right.
I mean, you mentioned the work of Plackett and Hewitt back in
60, yes.
and they had some notion of isoboles underlying the combination. And I
Do they?
suppose when you end up, which are contours,
Sort of around the whole grid.
combinations of doses with equal effect. And I suppose when you end up with 2 combinations, it's
There,
perhaps underlying this algorithmic approach, there's some notion of this isobole.
that they lie in some sort of group.
Yes,
Yeah.
they go that way. Yeah.
They go this way, this one?
Yeah, but you kind of need modeling for that because you
No,
could
absolutely.
have,
Yes.
you could have like 0 for 6 in one and 1 of 6 in the other,
Yeah.
both MTDs, but they're different.
Yeah.
Mm-hmm. Yep. So again, I have a paper on clinical trials with my friend Todd Alonso here. We just sort of wanted to look at this to show the clinical trials group what was being suggested in the JCO article. And again, it's unclear to me what these 3 A, B, and C's should be. Now, this is what the JCO article suggested just because that's what everyone's used to. Fan et al. Actually have a slightly different design from mine. They did a 2 + 1 + 3. And their goal was to speed up escalation when possible. Whoops. And then here are some other combinations. And again, you can see the trade-off too is that we're now talking about possibly 12 people per combination if you have to go through all 3 iterations here. We got 12 and a 5, 4, 3. And all these decision parameters, how many DLTs do you compare to the thresholds to decide whether to escalate or stop? They're all set to 1 just for convenience. Peter can attest to reviewing this article, that it was hard to summarize the results from all this. I tried, and I didn't quite like what I did, but it was an attempt here, because there's too many things to think about. I think algorithmic designs, people think, well, the Bayesian adaptive, I've got to come up with priors and models and so forth, and I don't find this any simpler. The design, what we found again is that the design will almost always come up with two different estimates of the MTC, the maximum tolerated combination, except if it's on the diagonal. If there is a diagonal, and that's an issue we can talk about. And again, this fast escalation doesn't appear to be any more risky than slow escalation, and sort of that's one of the takeaways I come from this two-dimensional dose finding, is that you should escalate as fast as you feel comfortable without skipping too many doses. Now, again, just like with the A plus B designs, the 3 plus 3 and so forth, there is an underlying targeted DLT rate that can be derived. I, of course, don't know how to do it in this setting now with the A plus B plus C. So the targeted DLT rate for each design is not explicitly known. If we use this design, what are we targeting? I have no idea. We did find overall that these three designs here tended to target lower DLT rates. I'm saying a differently opposite from my slides. These three designs tended to target higher DLT rates. But again, what that DLT rate is, I can't tell you. And there is an obvious cost and sample size here. I at least with my collaborators, I couldn't run these designs. They just wouldn't be willing to enroll possibly that many patients if there were 4 doses of each agent. So that's the algorithmic design, my least favorite approach, and hopefully my manuscript kills any future trials using that design, but I'm not holding my breath there. Bayesian adaptive design. Again, here's just sort of an outline. Pick a simple model for how the 2 agents now are going to impact the probability of DLT. And as I get to the end of my talk here, there are lots of us working in this area, and we all seem to pick different models, but it's not clear to me that any of us is doing any better than the rest of us. Got some parameters in that model. The general rule here, you pick some prior distribution for them. There is a caveat here as I talk at the end of my talk, is I think the model is irrelevant as long as this prior is given some thought. I have issues with designs that say we will come up with this model and then we'll just put a gamma distribution on that thing because it has to be positive. I think the investigators we work with are intelligent enough, they can at least give us some information that give us some idea as to what the prior should be. There has to be some information in the prior. I'm strongly of the belief that non-informative priors in phase 1 trials aren't the way to go. Again, elicit information from the investigators to figure out the best way to come up with this prior distribution. You're going to need a targeted DLT rate. What combination, what would you want to see from that combination? If I come away with it, should it cause DLT in 30% of patients, 20% of patients, so forth? And again, this elicited information is usually needed to figure out what these dose values, again, these aren't the clinical dose values. We've got to use that prior information to sort of back into those numbers to get the thing to work. But again, it seems like we all come up with different approaches for 1 through 3, but in the end, don't come away with that different of an answer. But we usually start a combination 1-1. I think that's a subject for debate now in this sort of 2-dimensional dose finding. If you're trying to sift through the 2 dimensions and find the best answer, should you really be starting here? If you think that maybe combination 2-2 is safe enough. Use the data, get the posterior distribution for theta, and then use this posterior distribution to figure out what to do next. And I leave that sort of vague because I think that's sort of up for debate in this 2-dimensional setting as to what you do with the posterior distribution to figure out what dose combination to assign to the next patient. And then 7, you just repeat until...
Are you doing this in the context where you have no information on the marginal dose response?
I'll get into that. That's sort of the elicited information I will have. Hopefully. It's unclear to me if the investigators even know that. But hopefully they know something about this agent and this agent, maybe not in combination, but at least by themselves. And again, until stopping criteria are met, whether that's a certain sample size, you've seen other stopping rules in the other talks. I typically don't use those as much as just coming up with a feasible sample size for the study, and that's when it ends, assuming all the DLT rates aren't unacceptable. So again, here's an example of a trial. I give you this is a true DLT rates, and if I'm targeting two agents that would in combination give about 20% DLT rate, I highlighted the guys in blue here that I think would be good choices at the end of the study. So again, we'll start down here and work our way around and hopefully end up somewhere here or near here by the time we're done. So after 5 patients, hypothetically this might be what happens. 2 patients down here, no DLT, so we escalate, safe, escalate, safe, and then we get up here and we see a DLT. So of course the algorithm is now going to backtrack. And again in this example, a DLT now occurred here, so the algorithm then starts moving around here with no DLTs observed. Again, moves around in this area, it doesn't see DLTs. Searches around here, and so now it's sort of getting an idea as to where it wants to be. After 20 patients, after 25, after 30, and after 35 patients, based upon the number of non-DLTs and DLTs in my model, everything's smooth together here. After 35 patients, the algorithm says that this is the maximum tolerated combination. Now, it doesn't lie on one of these blue, but again, this would be one simulation. But hopefully over many simulations, we get answers on these 4.
Do you allow the algorithm to pick a combination where there are no patients treated? Or do you have to treat them at
This algorithm didn't require that. So this would be an issue, right? I didn't treat a single patient here.
Don't climb all over you for that.
Mm-hmm, they will. They definitely will. But then, I see protocols where let's say we do this, additional cohort of 10 patients.
So does the algorithm choose more than one combination? This sounds like
This algorithm, the way I defined this algorithm was to pick, so as data's accrued, yeah, that's a good question. I said get the posterior, the average for each P, right? And pick the one that's closest to my target. So this was forced to pick one combination. And as I've worked in this area now for a couple of years and in other phase 1 problems, the question is if this has the DLT rate closest to my target, should I assign that combination or should I use some sort of, again, randomization? Thanks, Peter. You want to get your coffee, huh?
what was the target?
The target here was 0.2. Okay, probability 0.2. So these combinations are all...
Can you repeat what is, when you finish, what is your final decision? Which one you pick as?
The one with the posterior average probability closest to my target.
But didn't you have
12
DLTs and
two out of
12 or
12.
something like that?
That one is mine. Even ignoring your all your
2 out of
base, you
12.
take that one.
What's 2 out of 12?
Yes, the 2, 3.
The 2-3 combination, is that?
2, 3. Well, it's based on the prior in the model. I mean, I'm not saying this is... Right, this is just the data. Right, I don't know what, again.
Substantial data
I-
for a phase 1?
It's what if I didn't show you the posteriors means, but I bet these two are very close to each other. This one's maybe a point closer to 0.2, and that's why I picked this one. Again, an issue is that the
Well, of course,
the
you've got
best
a model
metric.
that's averaging in the two side
Mhm.
things, which are both higher than
Right,
the 112.
right, that's true. This are
112.
right.
So
That's
patient number
1-4.
5, when you were going up, boom, 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 and you went back to the 3-3 box,
Yep.
you could have gone back to the 3-4 or the 4-3.
You certainly could have. but-
It was just, so there's something about the way you model things that made that, what, closer to 0.2? Or
So yeah, so based upon these 5 observed data points and my prior in the model, this combination had a posterior probability on average closest to my target, closer than either of these did. And that's why it went there. So again, I have posterior estimate, the mean of the posterior distributions for all these combinations. I could randomize them, just because this one is 5 points closer to my target than either of these. Is that a reason to assign this, or maybe should I explore a little bit?
you know, a comment about, all of these methods go as close to the target as
Yes.
possible.
Yeah.
And that's not necessarily good. I mean, what ought you to do? You ought to say, the next patient, given that it's an ethical assignment, what gives me the most information and the fastest about finding the MTD? And it's not necessarily
Mhm.
aiming at that target.
I agree. I agree.
And keeping patients safe.
Yes, of
There is
course.
that issue
Yeah,
too.
I said that first.
Because they twice then.
Yeah. So I think that is a big issue in this. This is how to decide what to assign to the next person. And blindly, I went with what we typically did in the one-agent trial, which was to pick the closest. Now, some design considerations. So when I go to an investigator, at a minimum, what I would hope that they could tell me are these probabilities here. So you could either say that these are the marginals, you know, for dose 1, or excuse me, at the lowest dose of agent 2, what would be the DLT rates for every dose of agent 1? And whoops. This one should be highlighted. Sorry, I don't know why I'd wanted that one.
Well, you flipped the scheme over the course of
Well,
the talk.
That's because I had 2 sets of slides and I thought I caught it all to get them all to match. And you need to know, sorry, this row here. For the lowest dose of agent 2, what do you think the DLT rates might be for each dose of agent 2, right? So at a minimum, hopefully they can give me that information. You know, they could fill in the rest of this grid, but I feel like we start stretching the truth a bit more as we start to do that. Again, here's this slide trying to talk about what Don just mentioned and other questions is, how do I assign combinations to people during my trial? So once I've computed this posterior, the set of data I have so far, what do I do with it to figure out what to give to the next person? And again, the most common approach, as far as I'm aware of, is computing the posterior mean for theta, plugging that into my model to get an estimate of what that DLT rate is for each combination, and assign the combination that is closest to my target, P star. Now, in another setting that I'm working on in phase 1 trials, we have found that can be a problem when these PJKs don't change much. You can sort of get stuck in this contour, and where you go from there. And so again, this issue of exploring the data, learning from the data, versus trying to do what's best for the current patient. And restriction of assignments. Again, what I found in these studies is that, so if you're at 2-3, would you be willing to assign the next patient to 4-3, or even go all the way back down to 1-1? And my answer to both is no. Of course, we probably wouldn't want to go here. The clinician wouldn't want to do that because that is skipping 2 doses of one of the agent. But I have found, and we have found, I've worked with others as well, that going all the way back down, skipping both downward, is also a bad thing because now it pushes you all the way back. And to get back up to the upper right-hand corner can be problematic. And so I've seen others do this too, is that typically we say, find the combination closest to the target within a neighborhood of where you are right now. Right? So within 1 dose in that sort of a square around there. And don't allow yourself to go anywhere outside of that. So that if you need to go back up, you can do that fairly quickly. All right, I don't have much time, but I have one published paper and I have another one with a graduate student. Again, trying to model what's the right model for how DLTs occur with both doses. And this paper that I have said, well, each of these PJKs, let's assume they're betas. Because again, I like the beta distribution because its 2 parameters have nice interpretations. The first tells me how many people would have a DLT. This one tells me how many people would not have a DLT. And so I'll say each of those parameters varies with dose. Again, the number of people with DLT should go up with either drug. And the number of people without DLT should go down with either dose. And again, to get back to the drug interactions, there's no interactions here. This is already 6 parameters, which I think is a lot to ask for from 35 patients. So to put in interactions, 1 was going to be difficult, and 2, again, based upon what others have done before me, they found that putting an interaction didn't really help with dose finding beyond the main effects. And then, you blithely put priors. I'm going to put normal priors on all these parameters with some sort of variance that I have to pick myself. The mean parameters are all based upon the elicited data. So again, when I tried to show you the shaded row and column of elicited information, I can use those to sort of figure out the mean parameters. And then the variance parameter is sort of a knob that I tune to figure out by a simulation how well this design works. And then I use the information as well to get the dose values. Again, these doses of agent A and B, they're just based upon log odds ratios. So again, if the P's go up, then these have to go up, so the dose values go up, and everything is as expected. And in approach 2, which is sort of a month into creation here, it's one of those you just kind of hit yourself in the head and go, why didn't I try this before? If you think of each of these rows as its own one drug trial, again, you can just do the CRM for all 4 of those. Now, I know Ying Yuan has done this in another paper in a slightly different fashion. And then we just say that these 4 alphas have to be smoothed together so that I don't have 4 separate intercepts I've got to estimate. So the first intercept is somewhere, and then the differences between any 2 adjacent doses, the intercepts, follow some distribution. Again, these aren't constrained to be positive necessarily, because there is a normal distribution there. And then this is the effect of the other agent. And again, we can talk about whether assuming a single parameter, again, I'm on the Logis scale, I'm saying that as you move to the right, they all move at the same rate. Again, for simplicity, too many parameters. Because again, I've got to use the elicited information. I use these 1, 2, 3, 4, 5, 6, 7 cells to figure out the parameter distributions, the prior distributions, as well as the dose values. And so I've got too many things here. So again, by a simulation, my graduate student has found reasonable values for these parameters. I'm not saying that's set in stone at this point. You can use the elicited information to figure out the means of these distributions. Again, you've got to pick that one. Again, mu in this area on the Logis scale makes alpha 1, makes it very small, makes that p very small. So it starts out at the right thing. Dose values. So here's an example. 35 subjects, the same old setting here, 4 of each agent. I have a target of 0.2. I'm going to start at 1, 1, and I'm going to assign each patient to the closest. 2 scenarios here. Again, my target is 0.2, so here everything is safe, and I'd want to get down here as much as possible with as many patients there as possible. Here's scenario 2. Sort of a little bit different. There are unsafe doses. Again, the blue is meant to indicate at the DLT rate. Red is within 5 points, and purple is within 10 points, and more than 5 points. And so I go to the investigator here, and really the only information they would give me are these I've got everything flipped again, but again, the lowest dose of one of the agents in combination with the doses of the other agent. So based upon that information, I can develop my priors. And here are the results. So if Peter will engage me. Again, these are 2 different Bayesian adaptive modeling approaches. My metric here, because there's so many numbers to look at, is I took each of the cells' true probability rate minus the target, and then I multiplied it by the number in this cell here and added it up. So a metric of 0 would mean I always found the dose closest to the target. And so smaller metrics are better, right? So again, we do better than the A plus B plus C, which was 3 plus 3 plus 3. In this setting here, and the 2 designs really don't do very differently, as well as here.
Percentages of patients rather than numbers?
This is percentage of patients, the percentage of simulations in which this combination was found as the maximum tolerated. Oh yeah, I think there probably is. All right, so Bayesian adaptive over algorithmic. Again, I'm not seeing that there's one Bayesian design that would be preferred over all others. We seem to all be doing the same thing. And what do we do next? I know folks are doing this already. I'm not saying this is what I should be doing, but incorporating another outcome, efficacy into this situation. Time to follow up, I think. Again, a lot of these, we assume that everybody's fully followed in the data when we make our decisions, but I think there's something we can do there. And again, determining this best way of exploring all the combinations while still making sure we're treating patients fairly. All right? So, thank you.